The objective of this short review is for you to be able to look at hepatic vein waveforms and images of the hepatic veins and be able to determine and recognize it is congestion and what pathologies are causing that hepatic vein congestion.
So our hepatic veins are generally pretty small. They can measure up to 10 millimeters in diameter, so just 1 centimeter. You can see on this image here, these are very large, huge, dilated hepatic veins, large IVC in here. So this is very typical that you'd expect to see in a patient with right-sided heart failure or a massive congestion in the central venous system, high pressure on these veins.
So we can get large, dilated hepatic veins that you'll notice on 2D, and this is caused by right-sided heart failure or tricuspid valve regurgitation, or TR. And for that is because the tricuspid valve is leaking every time the right ventricle contracts, so that's pushing flow backwards, increasing venous pressure in our hepatic veins there, or also by a right-sided heart failure. As that gets more severe, we have more blood volume in the systemic venous system that's backing up due to the lower function of that right ventricle, which will then also lead to, again, more overly pulsatile hepatic venous waveforms. And we're going to discuss this on the upcoming slides in detail, but they're overly pulsatile. The S wave gets smaller or becomes reversed, and we call that a biphasic waveform or ASV complex. And this will also most likely show pulsatile flow in the portal venous system as well as it gets severe enough. So let's examine some of these waveforms on these upcoming slides.
Please check out the note sections on these upcoming slides. I copy and pasted and put them in there for you guys on purpose for reference. This is actually pulled from that supplemental hepatic venous waveform article that is on ICON. I highly suggest you guys giving it a gander or at least reading it through once, but I really like how they have this set up. So this is just going to kind of show us a progression of a normal state and as the tricuspid valve regurgitation gets more severe. So let's take a look at this again, guys, and I'm being redundant on purpose by describing these waveforms, but we have the A wave, right? And that's right atrial contraction, so we're going to have that reversal flow in the liver, so we're contracting the atrium, and the blood flow is going into the ventricle here. So then we have our S wave, and that's the filling of the right atrium during ventricular systole. So our tricuspid valve is going to close because our right ventricle is now in systole, and we're going to have that sucking of blood from that tricuspid valve into our right atrium. Then we're going to have that slowing of flow in the V phase, and that's just because the right atrium is overfilling just before the tricuspid valve finally opens up again. Remember, the V wave may reverse at the end there a little bit, but it doesn't have to in this situation. It's not. So it's just slowing of blood flow in this situation as opposed to actually flipping directions. Then we're going to have our D wave, and that's just filling of the right atrium during ventricular diastole. So remember, the tricuspid valve is finally going to open. Blood can flow passively back into the right ventricle and atrium there. Then as that starts filling up with blood again, before atrial systole starts again and contraction of the right atrium, reversal of flow. So just recap one more time. All right, so here is a waveform that is mildly abnormal. And we know that because the S wave is smaller than the D wave. So once you start seeing this S wave get smaller than our D wave, remember this should be our highest, dominant, tallest antegrade phase of the hepatic veins. And remember, that's filling of the right atrium during ventricular systole. So we're having some regurgitation, so we're having some decrease here of our flow, and that's the first sign and step of tricuspid valve regurgitation is a smaller S wave. So here's kind of that ASV complex I previously described that we would see in tricuspid valve regurgitation as it gets more severe. And that makes sense now that we have this visual, right? The ASV kind of just all flows together, and this little chart kind of shows you once it hits right here, we don't really see any flow in that one phase right there in ventricular systole. So we don't have any systolic flow there in ventricular systole in this waveform. And then there's one more waveform on the next slide where it's the most severe tricuspid valve regurgitation. And here we go. As you can see from our drawing here, we're going to have lots of retrograde flow. Notice it's going above, peaking in the wrong direction above the baseline. So you can see the ASV complex here, and you can see that we have retrograde, active retrograde flow, or peaks this way. Remember the previous slide? You can kind of see how it was it was decreasing during the S wave, but it was still above the baseline there. So in this situation, we have complete retrograde flow of the S phase there, and our biphasic waveform that we kind of typically see there. So we just have our ASV retrograde complex, and then the only antigrade is our D wave remaining, and that's just that filling of the right atrium during ventricular diastole, so at rest. So here's an example of severe tricuspid valve regurgitation. Remember that tricuspid valve's not working correctly, it's leaking, it's allowing blood flow to go the wrong direction. So in this situation, that we're seeing the ASV complex. The ASV are all blending together now above the baseline going retrograde. The only time we're having antigrade flow in the severe case of tricuspid valve regurgitation, so remember this is severe, is during the filling of the right atrium during ventricular diastole. So that blood flow is just able to still passively drop into the ventricle there and fill up in the atrium. So that's the only time we're going to see it's the D wave below, and then we're going to have the ASV complex above the baseline. So biphasic waveform, you see a biphasic waveform in a hepatic vein, you automatically think tricuspid valve regurgitation. Blood flow is leaking in the tricuspid valve going the wrong direction.
It's important to remember that congestive heart failure and TR commonly coexist together. But just to recap a waveform where congestive heart failure exists and they have a competent tricuspid valve, we expect to see pulse tau waveform, overly tall A wave and V wave, and that A wave's due to that increased backflow because that failing right ventricle is not able to accommodate the entire amount of blood from the right atrium that's contracting. So we get that overly tall retrograde flow during atrial contraction, and also our V wave. Our S wave, as the heart failure gets more severe, will start decreasing in size, similar to our early stages of TR. So as you can see, it's problematic in those early stages to differentiate the two of congestive heart failure or TR. So that's why you just think those two entities when you start getting this decrease in S wave compared to our D wave ratio. Now, in the end, the main takeaway here is if there is retrograde S wave, right, then we know at least some TR must be present.